evening. My name is Ethan Boger. I'm here to share with you notes I took at the 2017 PCRI Annual Conference held at the LAX Marriott on September 8th through the 10th, 2017. I was there as a participant, basically in the audience. There you see on this page you see my name and my email address. I would encourage you, if you have any questions about this presentation, or actually any other questions about prostate cancer that I might be able to help you with, to email me at this address, eb4452@gmail.com. My contact information is also on the PCIG website. The conference took place over 3 days, a Friday, a Saturday, and a Sunday. I was not able to attend on Friday, but this is the agenda for Friday's meetings. The ones that caught my eye that I wish I had been there to listen to was the presentation on space ore, which is the rectal protection for prostate cancer radiation. So it's a injectable plastic that is inserted between the prostate and the rectum that helps separate the prostate from the rectum and prevent injury to the rectum during radiation therapy. And it's gaining some traction in the urology world, and it would have been interesting to hear more about it. I was able to attend on Saturday and Sunday, and so this was the agenda for Saturday. And you can see there's many presentations. It was not possible to actually listen or attend every single one. Some of them overlapped, but the ones I did attend, and here's the Sunday agenda. The ones I did attend, by and large, are listed here on this slide. Slide number 5. And these are the ones that I took notes on, I think, except for one also that I missed, but I threw in here anyway. So on the slides after this, it will be basically a summary of my notes from all these presentations. And again, I'm not. I guess I want to qualify my remarks by saying that these are my personal notes. I cannot vouch 100% for their accuracy, so reader beware. I did also take some photos with my cell phone of the projected screen. Some of these photos may not be very clear, but that was the best I could do under the circumstances. The conference leaders are two very well-known names in the field, Mark Moryad and Mark Schultz. Mark Schultz is the founder and the director of PCRI, which is the Prostate Cancer Research Institute. He's famous for Invasion of the Prostate Snatchers and other well-known publications. Very well-known oncologist in the prostate cancer world. Mark Moryad is Director of Preventive and Alternative Medicine at Michigan University. He is also very well known in the field, and the two of them have been organizing this conference for a number of years. It's held annually, and it's attended by hundreds and hundreds of people. It's a big event, and I think it's very worthwhile going to it at least once to get a flavor for what's going on in the world of prostate cancer. They always bring in really good people who know what they're talking about. So the first presentation that I attended was about prostatitis and inflammation. So this is not exactly about prostate cancer, but it's connected, and it's presented by Dr. Nicol, who comes from he practices in Toronto, Canada. And so you can see here some bullets from things he said. Again, in no particular order, but one of the things he talked about was an ongoing cannabis clinical trial in Canada. And as you may know, cannabis has been anecdotally shown to be able to, um, well, either block or slow down the progression of prostate cancer. Some people, even some people you well know, have been using it, and I think the jury is still out. But at least now there's ongoing clinical trial. What does it mean, a clinical trial? But they are going to do a double-blind, uh, real scientific trial to see whether cannabis works. So they'll probably give cannabis, and I don't know the details, and he didn't really elicit what those details were, but they'll probably put one group in a control group that will not be getting cannabis, another group that will be, and comparing outcomes. And this usually takes years. And but apparently this has been ongoing and will be presented at the next AUA conference. And what is the AUA? The American Urology Association. They have an annual conference, a big show, and the results that are presented at AUA usually have some significance for the prostate cancer world. Okay, prostatitis. Uh, okay, so we talked about quite a bit about prostatitis. Um, he talked about the fact that even though so many people have it, there is no effective diagnosis or treatment to date. However, he did say that prostatitis is generally speaking not an infectious disease, not as a result of infection, but some other mechanism inside the prostate. Um, but it's characterized by inflammation, and the inflammation is diagnosed by histology. So they will take the biopsy or something like that, and there's 5 categories. I couldn't keep up with them, and I don't know exactly what those categories are. But so anyway, so well, even though they don't know how to cure it, but they do know how to diagnose it apparently. So to some degree. So there was a reduced trial. So reduce is the acronym for some trial, some clinical trial. And the purpose of that trial was to show that inflammation does or does not lead to prostate cancer. Now, if you've read anything about prostate cancer, they'll tell you that we don't exactly know how prostate cancer develops, but that one theory is that it starts due to inflammation, and that inflammation, reactive oxygen species and other things like that can eventually affect the benign prostate cells, the normal cells, start to affect their DNA and cause mutations, and that in turn might cause prostate cancer. Well, Dr. Nickel is of the opinion that that it does not. Uh, so that was a rather interesting point that he talked about. Now, the thing I put in the box, I seem to hear him say that patients that have prostatitis should not have radiation therapy, and I'm not sure this is true. So I put that in the box because I thought that was rather an important comment, but I'm not sure I heard it correctly. So if you have prostatitis and are considering radiation therapy, check it out. Ask your doctors about that. I'm not really sure about it. So for prostatitis and inflammation, he did recommend 2 supplements that I guess are used quite commonly used up in Canada. Quercetin, which you can buy over the counter anywhere, and dry pollen extract, which I had never heard of before, has the trade name Surnilton. So that was his presentation. Um, the next presentation was by Dr. Nordquist on immuno-ecology. Unfortunately, this one I could not attend. It conflicted with something else. But I did manage to sneak a couple of slides. This is what he was talking about. So these are some of the topics that are ongoing. There's immuno-oncology. We talked about stimulating the immune system to fight prostate cancer, and there's been a lot of ongoing research about that. This is supposed to be the layer, you know, the new kid on the block that's going to knock out cancer. Well, so these are the various therapies that people are talking about now. Okay, so interferon, which has been around for a while, vaccines like Provenge and Postvac, uh, checkpoint inhibitors. So actually, Prospect is a combination of vaccine and checkpoint inhibitor, and then some of these others. So unfortunately, I could not attend this. It would have been interesting to hear the discussion. The next presentation that I did attend was on high-dose brachytherapy by Dr. Jeffrey Demanis, who works out of, I think it's UCLA Medical Center in Los Angeles, of course. So high-dose brachytherapy is an interesting treatment for prostate cancer that's confined to the prostate. The method involves a temporary insertion, like 20 minutes, of seeds via catheters into the prostate. When you talk about seeds, I'm talking lots of seeds, like over 100, that are inserted using a very precise technology that Dr. Demanis says it works it's very accurate. So it very accurately places these seeds in the prostate. They use iridium 192, and like I said, the location is optimized with these visualization tools that he's developed. So anyway, the bottom line is, and the point of this kind of therapy is it delivers a very high dose of radiation to to very localized targets. So the whole point is to minimize radiation to the surrounding tissue without expanding treatment volume. So what does that mean? So he means that you can cover the entire prostate very well without having to radiate surrounding well tissue that shouldn't be radiated. In other words, the whole point of it is to give the prostate a very high dose without the side effects associated with normal EBRT, external beam radiation, which usually always has to go through well tissue and causes known side effects. So, having said that, he does not normally do brachytherapy alone. He usually does it with an added dose of EBRT, of external beam radiation. However, the EBRT dose is quite low. So most of the dose is delivered by the seeds. There is some dose that's delivered by EBRT. And the bottom line is that in his practice, he has very low rates of toxicity. Toxicities are bowel inflammation or bladder inflammation and so forth. And sexual function is, he says it's comparable to normal decline, which means as we grow older, all of us, our sexual function tends to degrade anyway. And so when you compare sexual function of men who've had HDR, which is the high-dose therapy, with the sexual function of men who have not had it, the rate of decline is roughly the same. In other words, he's claiming that this is a very good way to minimize loss of sexual function. Okay. As the space orb, this is one of the questions he was asked. He says that he uses it infrequently because the EBRT dose is relatively low, so there's less need for it. Now, he did, Dr. Demanis was very emphatic about emphasizing the need for HDR brachytherapy to be provided by somebody who really knows what they're doing. So somebody who's received quote-unquote excellent scores. I think that, not sure exactly how they evaluate each other, these radiation oncologists. But he says if you're going to do HDR brachytherapy, make sure you find a really good provider. Now one of the people he recommended was a Dr. Greg Merrick in West Virginia, which is quite close to Cincinnati. And he highly recommended him. And he also recommended Dr. Shu from UCSF. That would be in San Francisco. So there is a practitioner of HDR brachytherapy not too far from here. And if you're interested in this modality, you might want to check them out. Uh, if you want to learn more about HDR brachytherapy, Dr. Manis is open to, and he will provide a 2-hour consult. He didn't say if it was free or not. I can't be sure about that. But you can definitely find him. Just Google his name at UCLA, and I'm sure you can easily contact him. I did not get his phone number. I can't help you with that. So the next few slides are, photos that I took of the screen. They're not that clear, and I'm not even really going to try to explain them in great detail. But what he's trying to explain here, he's comparing the outcomes of let's see. Okay. The outcomes of various, well, it's not clinical trials, but it's the reported outcomes of various practitioners who've done HDR over the years, and so each row here is a particular provider, and then the first column is their name, the second column is the number of patients, and then the third column is F/U, which is the I believe it's the number of people, the number of men who suffer toxicities. I believe that's right. And this is okay. So this is for permanent seeds alone. So this is he's comparing permanent seeds versus HDR, so I better not say too much more about this. I think you should read it for yourself, and maybe if you have questions, we can talk about it on the phone. So the last three columns, though, are the percent of patients who are either low risk, intermediate risk, or high risk, and they are, it's rather important to distinguish between those. And the following slide will talk more about that. Okay, so here he talks about the number of seeds and the biochemical control. So you see on the first column here is the number of seeds that were implanted and the percentage of men who had the biochemical recurrence after X years. I'm not sure how many. So you can see that if less than 100 seeds are implanted, there's like a 53% chance of the disease not recurring. And as the number of seeds go up, you see that the chance of being free from biochemical recurrence, in other words, your PSA rising again, keeps going up. So if you get over 140 to 160 seeds, 95% of the patients did not have a recurrence after X years. I'm not sure how many. I don't remember exactly what he said about that. So that's what he's trying to say is you have to put in a lot of seeds. That's the bottom line of this one. Then he talked a lot about how he actually does it. These are the steps. The image-guided applicator all through the robotic treatment delivery. So it's pretty much been automated. And here's some of the tools that he uses. And this is a slice through a prostate showing where those seeds are implanted. And I guess what he wants to show is that they're implanted all throughout in a very precise pattern within the prostate, and get far enough away from the urethra to not damage the urethra, which is that the little circle in the center, the white circle. And so, uh, and that's, I think, the main point of this slide. Um, okay, and this is more about toxicity. So this is his information. Okay, so UCLA HDR monotherapy. Okay, monotherapy meaning no EBRT, right? And 10-year toxicity rate. So GI meaning gastrointestinal, and GU is gastrouro. So this is basically, yellow here is toxicities to the rectum, and blue is toxicities to the urethra or the bladder. And so, and grade 1 and 2, grade 3. So the higher the grade, the worse the toxicity. And so you see that in the GI tract, with the grade, there was 2% of grade 1 and 2 toxicities, and 0 grade 3, 4 toxicities. And see the similar kind of numbers for the GU tract. Basically, he's trying to say is that the toxicity rates for HDR are quite low. Here he talks about various kinds of radioisotopes they use in the seeds. And then this is a rather important slide. So he's trying to sell brachy combo. So what is brachy combo versus EBRT and surgery? Brachy combo is a combination of either brachytherapy combined with EBRT, or brachytherapy combined with EBRT plus ADT, plus androgen deprivation therapy. Now, if you read the, unfortunately, I kind of cut off the title of the slide. These are the combined results for high-risk patients only. In other words, they segregate between low risk, medium risk, and high risk patients based on their initial Gleason score or PSA, whatever method is used to stage the patient. But they were saying, okay, for low risk, maybe you don't even need to do radiotherapy. For medium risk, you probably do. But here we're only talking about the high risk results, the very worst patients. So this graph is showing what? The number of years, okay, along the abscissa here, and the percent PSA progression free on the ordinate. So he's obviously circling the brachy combo as being superior to EBRT alone and to surgery. So, okay, this is, the eternal battle between the surgeons and the radiation oncologists. And he is trying to tell us that, his methodology is far superior. Okay, now if we look really, really closely at these results, we see that, okay, the star is EBRT and C. So most of the results within the blue circle are for this combination therapy. But if you look carefully, the very, very best results seem to be the little diamonds, which is, if we look here, is EBRT, seeds, and ADT. So there is some controversy about whether ADT really extends life. Well, this is not mortality. This is about progression-free, being free of PSA rise after the procedure. And so the very, very best outcomes are way up here at 90%. And again, this is for high-risk results and all the way to like 10 years. Okay, but then there seems to be kind of a lapse, and the next data point for the diamond is way out here at maybe like 15 or 16 years. And the results are not quite as good. So after 15 years or 16 years, it looks like the percent progression free is about 75%. That's still really, really good. course, that means you have to tolerate the seeds and the EBRT and ADT for, I don't know for how long the ADT is given, probably 18 months or something like that. So that was his important takeaway. And the next presentation was about Axumin, which is one of the newer PET scans that are available out there. And this was given by Dr. Jennifer Kuyak, who works for RadNet. Now, RadNet is a publicly traded company. It's the largest imaging company in the United States. They have clinics really all over the country. I think, although they're mostly, I think, in the Midwest and East Coast. So she was there actually pushing, Axumin. In other words, RadNet is trying to promote Axumin as a PET CT scan for detecting, prostate cancer that is not in the prostate. In other words, for finding out whether, say, rising PSA after a prostatectomy might be due to a metastatic condition, either in the lymph nodes or in the bones or one of the soft tissue organs. So first of all, if you're more interested to hear about Axumin from this particular person, there is a link here to a website where they talk about Axumin. Okay, so first of all, what is Axumin? Okay, so Axumin is one of this family of new PET scans that tries to find prostate cancer where it might be throughout the body by using what they call a ligand, which is a molecule that is, or I guess it's more than a molecule, but I guess it's like a protein really, that is attracted more to cancer cells than to normal cells. Okay, so, and then they attach a radioisotope to the ligand, and they inject this thing into your body, and after about an hour, 2 hours, you would think that the ligand and the radioisotope would accumulate more in prostate cancer cells than in normal tissue, and therefore it would show up, it would glow in a PET scanner, and that's how they will detect your cancer. And the technology seems to be improving. In the last 2 years, we have Axumin, we have several other kinds of technologies that are all similar. They work in kind of the same way, in that you attach a radioisotope to some ligand which is attracted to the prostate cancer. Now, according to Dr. Kuyak, Axumin can detect a lesion as small as 2 millimeters. That's pretty small. There are some limitations. That is, it's not specific for liver and pancreas because the normal cells there will uptake this ligand, which in this case is a synthetic leucine amino acid. So what is this about the amino acids? Okay, all cancer cells are fast reproducing, so they reproduce at a faster rate than most cells in the body. Therefore, they need more energy. They need more ammunition to grow, and so they want to suck up anything you throw at them. They'll suck up this leucine. They'll suck up acetate and choline, which are short-chain fatty acids, which these cells will metabolize. And other kinds of cancer cells, most other cancer cells, are very avid for glucose. So if you have something like colon cancer or breast cancer, well, I'm not sure about breast cancer, but most other kinds of cancer, they'll give you another kind of PET scan with FDG, which is where the molecule is the radioisotope is attached to a glucose molecule and gets sucked up by cancer cells. Turns out that prostate cancer is not so avid for glucose. It's kind of the exception, but it seems to be avid for these other things, like this leucine, and there are other PET scans that we're going to be talking about later that are also based on this technology. Anyway, so some of the issues. First of all, the sensitivity. So, like most of the other new PET scan technologies, if your PSA is quite low, the probability of detection is not going to be that high, which is kind of a balancing act. If you want to have a successful PET scan that's meaningful, you want to let your PSA rise somewhat, but of course that means that the cancer is growing. There's more of it. It's going to be harder to treat. So there's a very delicate balancing act about when, how high to let the PSA level rise. So that's one issue, but that's not, that's a generic issue with all the PET scans. Another one is that it may be difficult to administer successfully. So what does that mean? This particular synthetic leucine is taken up by muscle cells, normal muscle cells. So yeah, it's tricky to administer, and sometimes the Axumin scans will be very difficult to read if some or most of the injected material is actually taken up by muscle cells. It's going to be more difficult to read the scans. So that is a limitation. Now, what is the advantage of Axumin is its relatively long half-life. So what is Axumin? Let's go back to the definition. The generic name for it is 18F flucyclovine. 18F is the radioisotope. It's an isotope of fluoride. So the advantage of that isotope is it has a relatively long half-life. That means that if you are the clinic administering this scan, you have a material that you don't have to, you've got almost 2 hours that you can have it. You don't have to have, you can store it somewhere to say some facility in, not necessarily in your clinic, and it's going to be available it's going to be effective for almost 2 hours. So some of the other radioisotopes have a much shorter half-life, which makes it much more difficult to deal with the technology, and that also has an impact on cost. So 18F is a highly favored radioisotope. It's not just used for accident. Okay. Now the disadvantage, one big one, is right now it is not covered by all insurance plans, and the co-payment could be somewhat pricey. She said something about $1,600. I've heard various different numbers. The cost of the system is quite high. These PET scans are not cheap, and one of the issues is that if if they're used more and more, there's going to be possibly some pushback from the insurance providers about having us take these scans. So the next slides are some of these photos I took from her presentation. Unfortunately, again, not that clear. This one is where she talks about some of the limitations of prostate cancer. Okay, this is FDG. I'm going to backtrack now. Sorry. So she did compare Axumin to some of the more common, or some of the other PET scans, and this is what I was talking about. That this is 18F fluodeoxyglucose, which is FDG, which is you can get this. You can go to Jewish Hospital and get one of these, or some other centers here in the city. But again, for prostate cancer, it's limited because, like I said, prostate cancer cells don't necessarily take up glucose. Here's another one, 18F sodium fluoride. Now, this is actually a very precise scan for bone mets. And it's also becoming more readily available. But she says it's sensitive but not specific for bone mets. Well, I don't know exactly what she means because I've heard it works really well. Okay, here's another one, C11 choline. So C11 choline has been around for a few years, but again, it has a very short half-life, only 20 minutes. So it's only available at very few centers. You can go up to Rochester and get one up there at the Mayo Clinic. But I think that's one of the only places in the country that has it. This one, the next one, Gallium-68 PSMA, is becoming more and more popular. It's been used in Europe for years. Unfortunately, we are way behind the 8 ball in this country. It's available in this country now in clinical trials. She says not FDA approved. Well, it's been FDA approved for clinical trials. Not readily available? Well, you can get it at least half a dozen centers around the country right now if you qualify for their clinical trial. But what is it? PSMA is a large transmembrane glycoprotein, which is, highly expressed by protein cancer cells. So a lot of prostate cancer cells demonstrate this antigen on the cell surface, and it's called PSMA. It's basically a protein. So it's stuck out there on the surface of the cell, and therefore it can attract. If we find an antibody that will attract to it, it will go to these cells. And if you attach a radioisotope to the antibody, well, then you can detect the prostate cancer. So, okay. So what she's trying to say here in the next little bullet is that, well, if you look at this slide really carefully, you see that it's excreted into the urine, so that you have this kind of halo effect around the bladder. This is, I guess, the kidney. I'm not sure what that is, but anyway, the bottom line is the kidneys are not the kidneys. The bladder sucks up the 68 Gallium PSMA, making it more challenging to read the scan in the pelvic area. Okay. So again, what she was trying to say is, well, Axumin is better than Gallium-68 because of that. But really, when you think about it, what you want to do is just have a very empty bladder when you get the scan, the 68 Gallium scan. And this is, okay, now this is, again, a slide on Axumin. And I think basically we've already talked about it. Okay. And here's a slide about how it works. Well, we've already talked about it, but just again, very briefly. What Axumin is a synthetic amino acid attached to labeled with 18F, which is the radioisotope. And it's recognized and taken up by amino acid transporters, which are pathways into the cells that are upregulated in many cancer cells, including prostate cancer. Okay. Okay, and here is a comparison of Axumin to some other. Okay. Okay, this is a result of clinical studies. And in this one, and I don't know if I can blow this up for a minute. Okay. In this one, what they're trying to show is the results of some studies, and you see that the control here is for PSA. So if you have PSA levels that are less than 1.78, okay, here's what you might get from the scan. So in this trial, there are 25 patients, and they had, of those 25, there were, okay, there were 11 true positives, 4 false positives, 9 true negatives, and 1. Now, these are, okay, these are all people who were proven to have um, uh, um, proven to have prostate cancer in the prostate bed. Okay, so I guess what they're trying to say is if your PSA is low, then you have a relatively small number of true positives and a relatively high number of negatives. Well, I guess these are true negatives. The bottom line is, as you go up, if your PSA is higher, if it's between 4.5 and 9, for example, uh, I guess, okay, there's more cancer, uh, but the probability of getting a true positive is almost, 21 out of 25, and there were 4 false positives. So it's trying to tell you that the higher the PSA, the greater the probability of detection. And this is another slide kind of saying the same thing. So again, if your PSA, this is again with Axumin, findings versus PSA level for biochemically recurrent prostate cancer. Your PSA is going up. Where is the cancer? Okay, so if it's in the prostate bed or extraprostatic, which means somewhere, I guess, in pelvis, and the other category is whole body. So here's a probability of detection, right? Or let me say, positively detected. This is the detection rate. So it seems to be that Axumin is better at detecting prostate cancer in the whole body, and not so much in the prostate bed itself. But definitely, as the PSA goes up, all of these rates of detection climb, and that's another piece of information about that. And here's a comparison of Axumin versus C11 proline, again, she's pushing her methodology. There's choline, there's Axumin, and it seems like the sensitivity and the specificity of Axumin is better than choline. And the overall accuracy is better. Now, this is, again, depending who you read. I'm sure that Dr. Kwan, I think he is up at Mayo, would probably challenge this information. Okay. And I did throw in my own slide here because after listening to Dr. Kuyak, I remembered a study that I had read comparing several of these new technologies, new scanning technologies. So I would remind the reader here that Dr. Kuyak has a personal interest in Axumin. And even though she said it's not, it has been compared, at least in one study, there are several, I think, where it's been compared to 68 Gallium and 18F DCF-PYL. And you can go to this, you can click on this link for the study. Now, this table was taken from that study. And what does it say? So it's looking at several of the new technologies. So F18, DCF-PYL. So DCF-PYL is another one of these ligands that's attached to an F18 radioisotope. And that one seems to actually be the very most accurate of all of the bunch here. But here are some of the others. 68 Gallium. Now, these are, okay, each row comes from the results presented by various clinics. And that's what the source in this column is. So these are various radiation oncologists or centers have published their results. And so this table just summarizes the results. So there's, here's several, this one, 68 Gallium PSMA HBED-CC. There's a large number of sets of these ligands. There's various it's alphabet soup of names, but this one seems to be the most popular, HBED-CC. And you see a large number of studies here. Here's 1, 2, 3, 4, 5, 6 of them, but I'll use 68 Gallium with this particular kind of ligand. And then there's the DCF-PYL, and down at the bottom is Axumin. So, and what is this doing? It's comparing probability of detection versus PSA. So PSA less than 0.2, PSA between 0.2 and 0.5, PSA between 0.5 and 2, and PSA greater than 2. So by the time we get to greater than 2, you'll notice that that most of these guys are quite accurate. You see 88%, 97, 86. F18 fluoromethylcholine, I'm not familiar with that one. Don't know much about it. It doesn't seem to be that good. But here's 95%, okay, 95%. And here's Axumin, 89%. So once PSA is over 2, these guys are all pretty damn accurate, and the probability detection is pretty high. The issue is what happens when your PSA is less than 2. And the probability of detection can be quite low, 31%, 11% reported, okay? And here's, 54%, 50%, 26%, 38%. And it starts to climb once you're between 0.5 and 2, and you can read that and see. So the takeaway from this table is that Axumin is okay if your PSA is over 2, and but you might consider some of these other technologies. For one thing, if you can get into a clinical trial, it'll be cheaper, and maybe you won't have to fly so far. If you go to NIH and you qualify for this guy, there's a clinical trial for this particular modality if you qualify, and it seems to be, at least in this range between 0.5 and 2, it seems to be the most accurate of all the technologies. Okay, having said all that, I think all these studies are based on a relatively small number of patients. So, the scatter in some of the data can be quite large, and that should be understood as well. So they're all just starting to use this here in America and the United States, and therefore the number of patients is quite limited. but it's very encouraging because these guys are a lot more accurate than what we used to have before. Okay, so the next presentation was by Dr. John Mulhall. Was about testosterone therapy, and there are actually been a lot of recent articles about testosterone therapy, and this is, for men who've been on ADT for a long time and are starting to feel the side effects. There's a growing trend to restore testosterone, and some men, of course, have low levels to begin with. And John Mulhall is a big proponent of that. So I took only a few. I have only a few bullets here. He's basically saying that there's a lot of concern about side effects of ADT on bone density, glucose control, which is diabetes essentially, and CVD, which is cardiovascular disease. So there is a lot of concern about the side effects of ADT. We also know that it affects cognition, and it affects a lot of processes in the body. I mean, our musculature, our energy levels. So it's not, men who are on ADT pay a penalty. So what Dr. Mulhall is saying is that anything longer than 18 months could lead to actual permanent damage. And when he talks about 18 months, he says patients should consider not only time on Lupron, but also recovery time, which can be 4 months to regain normal levels. Now, the next thing he said is, as from his opinion, is as long as the cancer is organ confined, there is no benefit to ADT. That is what he's claiming. Okay. The other thing, the next note I took was that what he was saying is that what is, what do you have, what level of control do you have to have for testosterone? Well, anything over 150 nanogram per milliliter, by the time you reach that level, the cancer cells are saturated. So if you're going to go on ADT, you really have to get the testosterone level down to almost nothing. On the other hand, if you're above 150 nanogram, your level really doesn't matter, because as long as it's over 150, your cells, your prostate cancer cells, are going to be saturated. So if your normal level is, say, 500 or 600, whatever it is, you don't have to panic that you're feeding your prostate cancer cells like crazy, because, by the way, it's really not going to matter. They're going to be happy, even at much lower levels. So he did mention that free testosterone is an important marker. It's hard to get a real accurate reading of it. It has to be checked with the correct assay, and he actually mentioned quest diagnosis for that. He talked a lot about erectile dysfunction, and he says that it's really, really important to try to maintain erections in order to maintain blood flow to the penis. It can be difficult to restore that if you haven't been able to do that. So he emphasized that. Okay, the next presentation was by Dr. Epstein, and it was titled the Pathology Report. So he basically wanted to give people a basic understanding of what the pathology report means. So Dr. Epstein is a well-known pathologist at Johns Hopkins. Many people have sent their biopsy samples to Johns Hopkins for second opinion. So he's considered the leading prostate cancer pathologist in the country. So he actually talked for quite a bit of time about the evolution of Gleason grading. So As some of us may know, the Gleason system has been around for a long time, like since the 60s. It's been over 50 years. But it's evolved over time. The latest iteration is in 2005. So this is an internal thing for the pathologist, but we should understand that. Uh, so in 2005, they changed the way they assign Gleason scores to samples. So a pre-2005 Gleason 3 is now considered Gleason 4. Therefore, the old Gleason 3s could have been invasive cancer cells. We all know Gleason 3, a lot of Gleason 3 tumors don't do anything, they're indolent, while Gleason 4 tumors can be very invasive. However, we should remember that if you were diagnosed before 2005, you better be careful because those Gleason 3s would now be considered Gleason 4s. Okay. Now, the next thing he wanted to talk about was the new grading system. So that was the next step in the evolution. So in 2014, all the pathologists got together and decided to replace a two-digit score, Gleason 3 plus 3 or whatever, with a single digit. Okay, that's because they didn't want to confuse us even more than we are already confused. So the so-called G1, I think they call it Gleason 1 or grade 1, is replaces 3 plus 3. That's a typo there. The new grade 2 is the old 3 plus 4. The new grade 3 is 4 plus 3. The new grade 4 is 4 plus 4. And the new grade 5 is the old Gleason 9 or Gleason 10. And he emphasized that the new grade 5 is a big step up in terms of aggressiveness versus the grade 4. So it's a big step up from grade 4 to grade 5. The next thing he wanted to emphasize were errors in diagnosis. So Dr. Epstein wanted to let us know that since there are very few pathologists around the country that specialize in PCA, therefore there's quite a range in diagnosis. And according to him, of everything that comes to Johns Hopkins, he says about 20% of the results are either upgraded or downgraded by second opinion. Okay, what else did he want to say? Low grade and high grade PIN can be ignored. He says that's not very important. But he did say that if your pathology report states intraductile carcinoma, that is not a good thing. So pay attention to your pathology report, see if it has those words in it. Then the following are, again, my photos taken of his slides. They're not that clear, and I'm not going to go over every single one of them. This is one you can find in any textbook on prostate cancer. Any book on prostate cancer usually has these slides that show you. So he was trying to say, here's how they grade the prostate cancer cells based on the new grading system: 1, 2, 3, 4, and 5. So I think it's pretty clear from this picture how different grade 4 is from grade 5. I think you don't have to be a pathologist to see that these grade 5 cells are widely different from normal cells, and much more different than, very much more different than grade 4. So that's what he was trying to emphasize. Then he talked about progression-free. Okay, what is the significance of the grading groups? Okay, why do they bother? Well, he says if you look at the percent probability of recurrence. Okay, so this is, again, recurrence means, okay, you've had surgery. Okay, years since surgery. Okay, you've had a prostatectomy. Okay, and they take your prostate and they section it and find out really what your score is. Okay, are you in, which grade group are you in? And then they monitor all these people over all the years, and they see that if you're in grade group 5, so all the men, they took all the men who were in grade group 5, and they found out what, okay, so 50% of the men had a recurrence after 1.5 years. Okay, that's the median, right? 50% of all those guys that were sampled had a recurrence after 1.5 years if they were grade group 5. But if they were grade group 4, 50% was like 5 years. Okay, so that's a big difference. 1.5 years, 5 years. And if you're grade group 3, 50% was it like 9 years. And if you're grade group 2 or 1, most of those guys never had a recurrence, which is why we say that grade group 1 is an indolent cancer that very rarely progresses. Okay. And this is, I think, the same data presented in a tabular form. And I'm not sure what this slide is and why it's different from the previous slide, because again it says probability of recurrence-free progression. I can't explain the slide except he presented it. If you have questions about it, call Johns Hopkins. And here's another one that I didn't quite understand, and I probably shouldn't even have shown it. If you can figure this one out, let me know. Okay. In this slide, he talked about the differences between the groups. And I think basically those Kaplan-Meier curves, the ones I just showed you, they more or less say the same thing. And here he talks about, against the continuation grade group 4 and 5. Okay, this is about post-cryo or HIFU. So if you have cryo or HIFU, well, I think what he means is if you do a biopsy on a prostate that's had cryo or HIFU, it's a different kind of animal in terms of what the pathologist has to do with the biopsy samples. And I think what the bottom line is that they have a much more difficult time doing a pathological diagnosis on a prostate that's been treated in this way. Here he talks a little bit more about how they report percent pattern 4, and this is what distinguishes between grade group 3 and grade group 4, right? Okay. And again, this is about a preoperative model to predict insignificant cancer. So this is again about the ongoing discussion in the prostate cancer world about when to operate, when not to operate. And this was Dr. Epstein's take on it all. Now, I did want to throw in, this is my slide, because after having read the grim statistics from Dr. Epstein, and remember, his business is pathology, I just wanted to shed a little bit of light, maybe a more optimistic light on prostate cancer and what it means to us patients. So, you know, when we go to the urologist and he tells us, oh, you have prostate cancer, we all tend to panic and say, oh my God, it's the end of the world. So, you know, we should understand that, you know, it's not a good idea to panic. And just the words here, patients should view the Sturm und Drang, which means, you know, the craziness of the prostate cancer generated by the medical community, like Dr. Epstein's slides, in light of a recent article called Estimation of Life Expectancy for Newly Diagnosed Prostate Cancer. So, what this article did is it says, what is the probability if you leave your cancer alone, whether it's low risk, medium risk, or high risk, if you just leave it alone, never get it treated, what's going to happen to you after 10 years, after 15 years? So, so this article I thought was very intelligently crafted. So here's an example. So, okay, if you have a Gleason 3+3 tumor, okay, like here's a bunch of guys who had an average PSA of 3.7 nanograms per milliliter and a Gleason score of 3+3. Okay, so after 10, okay, so of 100 men, okay, of a population of 100 men, okay, those that had a Gleason 3+3 tumor, the probability that, okay, the black are men who are still alive after 10 years, and red is the men who died after 10 years. Yellow is the men who specifically died of prostate cancer. So if you're going to die after 10 years, well, you're probably not going to die from prostate cancer. Only 2% of men out of 100, only 2 men out of 100 after 10 years uh, uh, would be dead from prostate cancer. And after 15 years, only 3 men out of 100 would have been dead. I mean, most of those guys would be dead anyway, but not from prostate cancer. So, and that's for a Gleason 3+3. Now, if you had a Gleason 4+4, which is considered a high-risk cancer, it's not, even that is not so bad. So, after 10 years, okay, well, what is it here? 15% of men would be dead from prostate cancer after 10 years. That is not a happy number, but it's not like everybody's going to die from prostate cancer. In fact, you're much more likely to die of something else. Again, so this, so, and after 15 years, what do the statistics look like? Well, after 15 years, all these people in red, they're going to die of something, whatever kills guys, right? Cardiovascular disease, other cancers, or being run over by a truck because you're not looking because you're old and not paying attention. So, but even for this high-risk group, only 18% of the guys would be dead from prostate cancer. So, it's not it's really not something you have to panic about. It's very important to be patient and remember that you are not, there are a lot worse cancers. We're maybe lucky to have prostate cancer and not something else, and we shouldn't be in a big hurry to do something about it. We should very carefully consider the treatments we want in light of the fact that we have lots of time to think about it.